Subbu is the most highly paid cardiothoracic surgeon in the city. So just in case you are having any doubt whether it's financially fetching or not, you have an example before you. But he will tell the professional examples for us. Thank you, Dr. Subramoniam.
Basically, the whole talk, the whole idea of the talk is to introduce you to what's the modern things, or what are the innovations which are actually happening in thoracic surgery. If you look at my practice now, 80% of the work I do now is not what I learned in my MCH. So thoracic surgery has come ahead in a long way, and I think when you choose your specialty, your super specialty, whether you want to go into cardiac or whether you want to go into thoracic or aortic, it's important to know what are the nuances, what are the innovations that are happening in each specialty. So additionally, we all know that when I went into cardiac, everyone told me that historically thoracic surgery has been compared to cardiac surgery to be a very poor alternative. The phrase poor cousin of cardiac surgery was a metaphor that we always used to hear, and the main reasons were that like Thomas was showing the heart looks like a glamorous, fantastic organ, but the lungs, chest wall and the other organs with the chest cavity are not so glamorous. So we always have a lower case load when we go into thoracic surgery when compared to cardiac. So you may be having around 6 CABGs a day, but you will have only 2 or 1 thoracic case a day. So if case load is low, that means your revenue generation is lower. You have less high profile cases. So the upper class is more likely to have a CABG rather than the lower classes, the lower middle class, who will be having tuberculosis and their complications. And of course, our country traditionally had a lack of a high quality training in thoracic surgery compared to cardiac surgery. So has thoracic surgery evolved in 2025? So that's the posterolateral thoracotomy. There's a standard incision that we have seen in thoracic surgery over 90 years. We have a lot of scientific disadvantages, but I'll be focusing on what a CVTS postgraduate in 2010. I was a CVTS postgraduate in 2010, and we thought it is a pretty inferior operation compared to cardiac surgery. We used to operate in a small OT where people who were not really competent to do cardiac surgery were actually relegated to that OT. So there was a significant lack of glamour, heroism and money as far as thoracic surgery was concerned. Now that all changed when the thoracic surgery moved onto a minimally invasive platform, and the first platform that came to prominence was video-assisted thoracic surgery, which we know as VATS. And it was Robert McKenna who actually started VATS in 1994, and this was the first significant paper that came out in 2006 with his experience in lobectomy in 1,100 cases. So we all know what VATS means: visualization on a 2D monitor, small incisions, no spreading of the ribs, and any incision less than 6 centimeters is considered to be minimally invasive. So that immediately changed the way we were seeing thoracic surgery as a specialty. It became more of a glamorous specialty. It became more of an innovative specialty. Now, I started my career with very simple procedures: diagnostic biopsy. I used to do around 25 lymph node biopsies before I actually was allowed to do something more on VATS. And that's where a lot of people used to be very skeptically come and stand outside the OT and see what a guy was doing, trying to take a lymph node for 2 hours. So we all start slow, we all start start small, but then we slowly start going up on our levels, from a level 1 procedures to level 2 procedures like a bullectomy, decortication, sympathectomy, mediastinal tumors, and then the thymectomies. And then when these innovations came into our specialty, like these endostaplers, which we basically used to control the vein, the artery, and the bronchus, these ligashos, the ultrasonics, and the endobags, that's when really lobectomy started to be performed in a big way. And that these pictures actually show the journey of the evolution from an invasive specialty to a minimally invasive specialty, from 3-port to 4-port to now uniportal VATS. So thoracic surgery, as far as VATS is concerned, has come a huge way. Now, once we do lobectomies, you can't simply be a lobectomy surgeon only, because you need more case numbers, so you go into newer avenues, like you can use VATS in cases where you have palmoplantar hyperhidrosis to do a VATS, bilateral thoracic sympathectomy. You can go on to do pleurectomy or decortication for rarer malignancies like a mesothelioma. You can go on to do a bit of cosmetic work like a pectus excavatum repair, where these are all the innovations which have come about in pectus repair, which you do with VATS. You can have the I pattern, the X pattern. These are all newer avenues into VATS, which are actually not there 10 years back. Now, if you go into trauma, you can actually use VATS support for surgical stabilization of rib fractures, where you can evacuate the hemothorax. You can go in through the ICD tube, make it a uniport. You can evacuate the hemothorax. You can repair the lung injuries, identify some diaphragmatic tears, which you see here. Diaphragmatic tears are rarely seen on the CT, so that's where VATS becomes important. You can assess vascular structures, and more importantly, you can actually mark your fracture segments, so that you can convert your huge posterolateral thoracotomies, which you used to do initially, into these kind of small mini incisions, and you can repair the fractures. So VATS certainly has its own newer avenues, which we all as surgeons need to explore, so that the case numbers are high, and we'll be able to justify doing VATS in a specialty. So VATS already has had an established platform in thoracic surgery, but by 2001 people have started moving into robotics. So thoracic, although robotics was initially designed for cardiac surgery, it was actually thoracic surgery that actually took up robotics in a big way. So this is the initial paper by Melfi et al. It was way back in 2002, where they have demonstrated robotically. They have done around 12 cases, and this was the first paper that came way back in 2002. So minimally invasive thoracic surgery, although it has evolved, VATS had some negatives that was preventing people from really adopting VATS in a huge way, and these were the shortcomings that robotics addressed with intuitive movements, 3D visualization, and also assisted instrumentation. As you can see here, all the procedures that we do on VATS or open can also be done on robotic thoracic surgical procedures. But two procedures which I will definitely prefer to do robotics if I have access to a robot will be a thymectomy and the first rib resection, and maybe a mediastinal tumor. So these are three tumors where actually robotics has been shown to have a lot of value. Now, there's a series of 251 cases where you can see the whole range of procedures can be performed on robotics with around in our series is more of lobectomies, and then comes the mediastinal tumors and the thymectomies. Now we have moved exclusively to the robotic platform as far as mediastinal tumors and thymectomies are concerned. Now, this is an example of how robotics actually helps you in a massive way, especially when you do a thymectomy, which is a work or a surgery that actually happens in a very confined space in the retrospinal area, and the increased visualization and the articulation of the instruments are so superb when you go and do a thymectomy. That visualization of the bilateral phrenic nerves are going up to the thyroid, inferior margin of the thyroid, and taking off the cervical part of the thymus gland, and all becomes so easy. And as you can see here in myasthenia, you need to completely bear the fat over the pericardium, over the aorta, and over the innominate vein. So that's where robotics really adds a lot of value to your practice, especially in thymectomies, mediastinal tumors, and first resections. Now, staplers, sure form staplers is another technology which has really revolutionized robotic thoracic surgery. We had a situation prior to 2022 in India where we use manual staplers which are actually fired by the assistant surgeon at the table while the surgeon is sitting quietly at the robotic console. But now with sure form staplers, the stapling is handled by the surgeon himself, and that actually increases confidence in vascular stapling in robotics lobectomy, and that is a significant development that has recently happened in robotics. So it also has AI technology which actually analyzes the thickness of tissue. It tells you the appropriate stapler to fire. There is graded clamping, compression of lung tissue, and that all contributes to minimizing your air leaks. So now these are situations that we see in India, maybe not so much in the Western world. There's a bronchiectasis in the left lower lobe, and we are doing a robotic left lower lobectomy. And it's been clearly proved that even when you have significant adhesions in the chest, robot adds value to your operation. Your tactile stimulation is actually a bit deficient, but it is more than compensated by your visual feedback. So that's how thoracic surgery has really advanced through two minimally invasive platforms, one being VATS and the other being robotics. So these are the postoperative scars that we see on robotics, and you can see it's a real far cry from the post-operative thoracotomies that we were used to doing, and you can see how at around 1 year you can hardly see the scars, and these are all the way the scars look once we do a robotic thymectomy and a lobectomy. So the future as far as robotics is concerned is very bright. We are looking at the SP robot coming to India pretty soon, where it will be a single 2 centimeter port. You are going to do every operation uniportly. There's no question of any intercostal neuralgia here, because the port will be in the subxiphoid area. You are not going through the intercostal spaces at all. So with more surgical robots like these coming into the market, the cost of robotics is also supposed to go down. So we will see more and more robots coming into the market, into more hospitals, and I think slowly in 5 years you will see more robotics being performed than VATS. Now, COVID pandemic into 2020 actually opened up a new avenue for thoracic surgery, and that was lung transplantation. And we did our first lung transplant in 2021, and COVID has actually spurred a lot of transplant activity in our country. And over the last 4 years, we've done around 84 transplants. And as you can see in India, unlike in the West, where it's more of COPD transplants that you see, in India it's more of ILDs that we handle here. And that's a peculiarity of India. We don't have much of COPD referrals in India at all. It's predominantly ILDs and infective pathologies. And therein lies the challenge. Now, like you see here, this is a case of parakeet poisoning, but you're hardly seeing any lung parenchyma there. No viable lung parenchyma. This is a patient who's not going to go anywhere without a lung transplant. They land upon ventilation and ECMO pretty soon, but after the AK and the liver failure results, you can actually take them out for transplant once you're sure the urine parakeet levels are negative, and that's how they are being assessed neurologically after around 3 weeks on the ECMO and ventilator. You have to make sure they are neurologically normal before you take them up. And that's how the young people, the parakeet poisoning predominantly, they are a young cohort. They are all young patients, and they do very well by around the third day, even though they are on ECMO for around 3 weeks, and by a year they recover to a level where they're pretty normal, and they're doing rehab that we may not be able to do on our own. So another situation that we would see in India, just to tell you that once you start doing lung transplants in India, it's totally unlike what you see in the Western world. You see CTs like that with silicosis in a glass blower, very tough pneumonectomy. So in India, the problem that you guys will face will be a more difficult explantation pneumonectomy than an implantation. Implantation is far easier. These are patients who recover quite fast by around the third day, and that's them after 2 years after a transplant. And since the last two ND procedures, we are trying to amalgamate a thoracic experience into a lung transplant experience, where we use VATS for additional lysis, especially if we do a bilateral bronchitis and all. We see a lot of additions. We need to keep our incisions pretty small, and because we want to keep it small, we try to avoid the clamshell incision. We try to put a bilateral anterolateral thoracotomies where they come off ventilator pretty fast post-op, and that really helps in decreasing morbidity and an early recovery. Now this is a very special slide. Now this was the 34-year-old patient who had bilateral bronchitis. The man you're seeing there has underwent a bilateral lung transplant, and he became the father of his second kid 3 years after a lung transplant, and that really shows how much their quality of life becomes superior when compared to the point they were prior to transplant. And so, as a thoracic surgeon, earlier it used to be a single thoracic surgeon working, but now we have thoracic surgery teams where you have your comparators, you have your colleagues, you have your thoracic anesthesiologist, you have a full team supporting you, and like cardiac, you also work like a team, and the quality of life is something that we have to think about when we talk about choosing a specialty. Thoracic surgery has advantages of an elective plant surgery. You're not going to be called, most probably you won't be called in the middle of the night to do an emergency CABG. Your morbidity is less, results are superior, especially when you do VATS and robotics. You have gone into a stage where we have better income generation when compared to cardiac. You have a better quality of life outside of working hours, unlike cardiac surgery, predominantly because you have no low cardiac output syndrome in thoracic. You have no re-expirations for bleeding. You have no emergency surgeries. You need not really be bothered about somebody else's urine output. And you don't have pulmonologists snipping at your heels like cardiologists do. So on the whole, it's a better job satisfaction. You get a good networking opportunity because the community is still small, and most importantly, you have all the time to spend the money you earn. So this is a funny video I saw, but I think it explains where thoracic surgery presently is. Thoracic surgery, the poor cousin metaphor may have been accurate in the past, but it no longer reflects the current reality. And thoracic surgery is now a highly specialized and respected field, and advancements in thoracic surgery and growing recognition of its positive impact have led to a positive perception, and I think thoracic surgery is truly now the rising star of CVTS. So I hope at least if I have inspired one of the PGs here to take up thoracic, it'll be superb. And that is thank you. That's my unit, and I'd also like to use the opportunity to say that we do have a lot of training programs in my unit. We have a 1 year and a 2 year fellowship batch program. We also have short observership programs. If you are interested in lung transplant, we have a lung transplant fellowship program also now. And we do around 3 batch workshops a year. So anybody who's interested in thoracic VATS, who wants to get trained in that, they are welcome to contact me. Thank you.
Any questions from audience?